Kiwis will now be able to get 12-month prescriptions on some medications rather than the current 3-month limit. The change announced in yesterday's budget, along with $91 million to cover the cost of the extra medications prescribed. Health Minister Simeon Brown says it could save patients up to $105 a year in GP fees. But there are questions around whether it could create risks to patient safety. Earlier, I spoke to Dr. Luke Bradford, Medical Director of the Royal New Zealand College of General Practitioners, and began by asking if GPs agree with the change.
The college submitted on this quite strongly that we felt that there was room for movement and we would have been supportive of a 6-month change, but we have concerns around the 12 months. It allows a certain length of absence from review that worries us.
What are the safety considerations then that are going to be needed to implement this safely?
Well, I think it has to be recognised that it's a patient-by-patient policy, and so it depends on what medicines you're on, for what conditions, and the number of different meds. And it depends on what kind of level of monitoring is needed for that. So a discussion is going to have to happen between the prescriber, normally the GP, and the patient, so they understand what can happen and what can't, and the length that's suitable for them.
So what are some of the health conditions and perhaps the drugs that might fall under this new 12-month prescription plan, and especially given that you thought 6 months was a better option?
Yeah, so I think if we review what actually happens when you request a repeat prescription, that helps. And so what would happen is the doctor would look at your request, they'd look at your notes, they'd look for updated blood tests that related to your condition or your blood pressure, your latest observations, and any other changes that have happened in that time from other prescribers at the hospital, for instance, and then decide if the medicines are safe. So what we will be looking at is which medicines you can do that with and leave for 6 to 12 months and which you can't. So typically those 12-month ones would be people on well-controlled conditions and probably only 1 or 2 medicines. Things like well-controlled thyroid disease, well-controlled high cholesterol, perhaps some well-controlled gastritis on something like an omeprazole. That would be fairly typical, would be okay. There was an example given by the minister around insulin, and that definitely wouldn't be normally okay for 12 months without review.
So a bit of a disconnect here between what we're hearing from the Ministry of Health and what GPs in practice are actually thinking. I mean, are we going to see a situation where vulnerable people, sick people, are falling through the cracks because they're not going to see their GP as often, potentially?
I think we will ask to see the patients who need seeing. I think safety is our number one priority. So I hope that's not the case. What we're likely to see is that work that goes on when you request a repeat prescription rather than when you come in either won't happen, which is a concern, or will happen, and the GPs will just have to do it in their own time.
And just finally, in terms of the spend on health, do you think this is the best use of $91 million?
It's a very interesting calculation. There's an assumption that will be the effect of increased medication pickup. I think time will tell if that's the case. I suspect that people who are phoning in for prescriptions are actually compliant already on the meds. So I suspect that money won't be spent there, but it certainly will come out of GP income, and this will have to be covered under capitation.
OK, Dr. Luke Bradford, the Medical Director there of the Royal New Zealand College of GPs. Thank you for your thoughts on this. Ngā mihi.